Thanks again for inviting me. Alex assigned me to the talk title OCT Where, and I just interpreted that to mean what parameters should we be watching in glaucoma. Ted presented a wonderful overview of all the possible things to look for, but I think we need to be a little more focused because I'm just not as smart as Ted and I can't integrate all that information. So um, I do have one relevant financial disclosure. There's a patent that's been licensed by Zeiss that I'll be talking about here. So we have these broad categories of parameters, and within them, there are many different numbers that we can look at. The retinal nerve fiber layer was the first that was developed with OCT. Stratus OCT had very strong retinal nerve fiber layer analysis with the scan circle, but not very good optic nerve analysis. The HRT was much, much better than that. With spectral domain OCT, really we have both available and both are quite robust. And now completely new with spectral domain OCT is retinal ganglion cell layer thickness and retinal layer thickness. So this is a typical printout of a serous OCT in a patient who has glaucoma only in the right eye. And I like to look at the thickness maps and look for asymmetry between the butterfly pattern, which is quite evident in the left eye, but is lost in the right eye. And you can see areas of what are retinal nerve fiber layer defects. But I think they're easier to see in the deviation map. And these areas really are the same as those we used to see on red-free photography for retinal nerve fiber layer thinning. This is a figure from Chris Leung showing some classic retinal nerve fiber layer defects that would be consistent with glaucoma. And so this is what I'm looking for on these maps. And it can be very helpful to look for these because sometimes they don't extend out to the scan circle and might be missed with your pie charts, I call them, which we'll look at next. These are the pie charts of that same patient and very easy to interpret using the red, yellow, and green convention of green being good, yellow being normal and only fewer than 5% of age-matched controls, and red being normal and fewer than 1% of age-matched controls. So super easy to interpret. And then these Tisnet plots of neuroretinal rim thickness, which we probably don't look at enough anymore, but is quite robust for glaucoma, as we learned with HRT, and retinal nerve fiber layer thickness Tisnet plots. These are super easy to interpret as well, as the solid line represents the right eye, dashed line the left eye, and the green is the whole range of retinal nerve fiber layer thickness that's was found in the normative database for a patient in a 10-year age range. And if the patient's line falls within that range, then they're normal for age, whereas when it dips down into the yellow or red areas, it's abnormal for age. And this can be helpful to look at because there are times when very thin retinal nerve fiber layer defects can straddle 2 clock hours and not show up as yellow or red, but there's a definite abnormality. The manufacturers fortunately use the same color convention. Perhaps different areas are represented, but this is Spectralis OCT showing red sector instead of a clock hour, and the rest of it green. And here's the Tisnet plot for Spectralis. And then RT view, again, you're getting the same information, but just displayed differently. The sectors here, there are 16 sectors instead of 12 clock hours. And I think you can appreciate the retinal nerve fiber layer defect here that is shown on the RT view in that area. And again, loss of the double hump pattern, it's been called. This area goes in the red on the Tisnet plot. And so the second set of parameters one can look at are the optic disc parameters shown on this chart. I forgot to mention the average RNFL thickness, which obviously is the average of the scan circle here, very important for diagnosis and progression. But the optic disc parameters include rim area, average cup to disc ratio, which is the average of 180 cup to disc ratios all the way around the cup, vertical cup to disc ratio, and cup volume. All were found to be highly discriminatory between glaucomas and normals early on, and that's why they're displayed. And then a helpful parameter that most of us are probably ignoring is disc area. You know, we used to use our 90 diopter, 78 diopter lens to measure vertical disc diameter, and that was a bit tedious. But with OCT, disc area is measured as the end of Brooks membrane, and we can decide whether a disc is small, medium, or large based on that number. And then the ganglion cell measurements were noted to be important 20 years ago, that 54% of our ganglion cells reside in the macula. And Ranzheimer first suggested that we should measure this area, and OCT is the first device that allows us to measure the actual ganglion cell layer, if you will. And actually, Doctors Tan and Wang working at Doheny were the first to segment the ganglion cell layer with the RT view. This is an ultra high resolution image that I like to use to show you the difference in ganglion cell segmentation between the two instruments that do this. The ganglion cell complex, or GCC, with the RT view includes the retinal nerve fiber layer, the ganglion cell layer, and the interplexiform layer, all in the sandwich that's measured in the macula, whereas the serous OCT just subtracts out the retinal nerve fiber layer and gives a measure of the ganglion cell layer and interplexiform layer. So the measurements are obviously going to be different. But the map with the RT view, which, as I said, was the first to segment these layers, there are two maps: a color-coded map with a different color convention where black represents a 50% loss of GCC and blue represents a 30% loss of GCC. But there's also a significance map which has the normal color designation of red being found in fewer than 1% of age-matched controls and yellow fewer than 5%. And so, for instance, in this patient with an inferotemporal retinal nerve fiber layer defect and a suspicious area here as well, the GCC shows the corresponding area of the ganglion cell layer in the macula that's lost. These axon bodies, are these retinal nerve fiber layer bodies, are connected to the axons that make up the retinal nerve fiber layer that we just saw that was lost. And even in the left eye, we see some loss of ganglion cell complex corresponding possibly to that borderline axonal loss. The serous OCT was the second to come up with ganglion cell layer segmentation, and that instrument measures an ellipse of data, of course subtracting out the fovea, and presents us with 6 sectors and some quadrants. And having a little trouble, there we go. And basically gives us a numerous GCIPL parameters, including a new parameter called minimum GCIPL thickness. This is the thinnest of 360 spokes emanating from the fovea out to that ellipse. And the thinnest spoke around actually is a good discriminating factor between glaucomas and normals, and may have the highest discriminating factor of any of our GCIPL parameters. So maybe something to pay attention to. So this is a patient measured with both instruments, the same patient with an inferior arcuate defect and nasal step with corresponding GCC loss, as well as lots of GCIPL loss. So we're getting the same information with the instruments, just presented differently. So here's a case of a patient who converted from ocular hypertension to glaucoma with elevated pressures initially. Prostaglandins maintain the pressures in the low region, and this left eye has a focal thinning of the neuroretinal rim with a corresponding visual field defect in that affected left eye, and large areas of retinal nerve fiber layer loss that shows up on our deviation plot and pie charts, as well as thinning of the GCIPL. And as Ted said, it's incredibly useful when the structure function relationship lines up all in a row. And I think our certainty that someone has glaucoma increases as there's that structure function correlation. But unfortunately, that's not always the case. And I've shown you a couple dozen parameters that you can focus on, and most of them have excellent discriminating ability between glaucomas and normals. So as the technology developed and we added optic disc parameters to retinal nerve fiber layer parameters and then added ganglion cell parameters, it became almost overwhelming to know what to look at, which is why I think Alex wanted me to talk about OCT wear, because, if you add all these up, certainly average RNFL thickness is still one of the most important discriminating factors, and also the thing to look for in progression, as Ted said, because it's extremely reproducible. But there are 4 RNFL quadrants, 12 clock hours, 4 optic disc parameters, and 8 ganglion cell parameters on the cirrus spectral domain OCT. And the problem is that they correlate very well with each other, but sometimes they contradict. You might see an abnormal ganglion cell complex sector or two, highly abnormal, with a normal retinal nerve fiber layer, and you don't know what to do with that information. And similarly, some of these are so highly correlated with each other, like the inferior retinal nerve fiber layer defect that I showed you and the GCIPL, we're measuring the exact same thing. Those cells are dying, and we're just measuring it twice. So we need statistical tools to combine the information that we're getting now, because our brains are just not big enough to sort this out. At least mine isn't. I know Ted's a lot smarter than me, so he's got this all figured out. So we started to explore this. Should you require a retinal nerve fiber layer clock hour quadrant in the red and yellow and a GCIPL abnormal measurement? Or can you have either one? Can it be and or? And what gives you better discriminating ability without having too many false positives? And so we started to explore this in a very simple matter by, let's say, looking at the sensitivity and specificity. If you require the minimum GCIPL thickness, which we said has the best discriminating ability in that group of parameters in the ganglion cell parameters, or average RNFL, which has the best discriminating ability of any of the RNFL parameters, and you end up with a sensitivity of 94% and a specificity of 85% if you use OR. But if you start using AND parameters, it's 96% and 63%. So it's very difficult to actually use this kind of information on the fly in your clinic to decide whether this combination of abnormalities actually represents glaucoma or not. So here's an example of a confusing case. A 68-year-old African-American man referred by our retina service for intraocular pressures in the 20s and large cup to disc ratio, which we know is typical of African-Americans, and a strong family history of glaucoma. He has a brother with severe glaucoma, but no other known past ocular history, with pressures of about 20, relatively thin corneas, also typical of people of African descent. And these were his optic discs, the right eye stereo photos, and left eye, so not frankly abnormal, completely normal visual fields. And these were the OCTs. And this is a very common consultation for a glaucoma subspecialist. And so here we have a patient who really has average RNFL thickness, clock hours quadrants in the green, but we're seeing a fairly dense defect in the GCIPL here that's not showing up at all in our visual field, and there might be some early changes in the en face image, but that's not really captured well in our um, clock hours because it straddles a couple of clock hours and is quite thin in the scan circle. So, basically what we can do using exploratory factor analysis is look at all those parameters that I just showed you, put them into a Bayesian analysis model, and come up with a predictive ability that the right eye, which did not have any red or yellow, has a 9% chance that that scan represents glaucoma, whereas the left eye with that ganglion cell IPL defect and minimum rim thickness, an 80% chance that that represents glaucoma. And so this exploratory factor analysis is a statistical method to decide whether 1 plus 1 equals 2, which would mean the retinal nerve fiber layer being abnormal plus the ganglion cell being abnormal increases the probability of glaucoma, or does 1 plus 1 equal 1, in that we're measuring the same thing, a positive retinal nerve fiber layer that's connected to those ganglion cell bodies doesn't increase the probability that you have glaucoma. And so the way to do that is to take all the parameters that I showed you in a large group of normals and glaucomas and do an exploratory factor analysis to sort that dilemma out. Can we bunch factors that are telling us the same thing and separate them from factors that tell us different things? And so what that looks like graphically is taking all 17 numbers that we get and doing Bayesian analysis that sorts out in groups of factors what are the same, which is all GCIPL parameters, all optic nerve head parameters, and these 3 retinal nerve fiber layer parameters, and then these 2 that sort of sit apart, and then put those factors into a logistic regression now that we've put them down into 5 categories without giving any information to the machine classifier, and put them through logistic regression to come up with a single number or probability that that OCT represents glaucoma. And so having done that, we discovered that the combinatorial analysis has a much better discriminating ability between normals and people with early glaucoma than any of the individual factors that had been found to be highly discriminating on their own individually. And we've just validated that in an independent data set of very early glaucomas, all of whom had mean deviations that were -4 or better, and a subset that actually had very early glaucoma of mean deviations of -2 or better. And using the formula that I showed you, we're able to demonstrate in this independent data set that in early glaucomas, the index has the highest discriminating ability with the best sensitivity and specificity at 95 and 99% compared to other individual parameters used in isolation. And so in this way, we're able to discriminate glaucomas from normals even in an extremely early stage. And this is an example of 2 glaucoma suspects with almost normal OCTs, and you can see all the pertinent data here. And there's not a lot of yellow or red here on either scan, but using the formula, the OCT index is 0.9 in this glaucoma suspect A, meaning there's a 90% probability that that scan represents early glaucoma, versus the left eye, which is only a 17% probability. And we found, just like with the GDX NFI, nerve fiber index, there is a cutoff at about 0.34 that could lead the clinician to conclude that this is a structural indicator of early glaucoma, and anything below 0.34 is not. Certainly, the higher the probability towards 1.0, the more certain you are. So anyway, we have all these parameters, dozens of them now, but we can put them into a formula to come up with a single index. What's nice about this model is that the next stage would be to add visual field mean deviation, pattern standard deviation, age of the patient, positive family history, adding additional factors that would increase your clinical suspicion of glaucoma can also be added to a model like this to come up with even more robust probability indices. So thanks again for inviting me. It's great to be able to share this with you.